Nearly there. Hi, Ted.
Hi.
Nice to see you.
You too. Thank you. Thanks for inviting me.
Oh, pleasure. I've heard you're a superstar.
Not sure who from, but
Other superstars, so it must be true. All right, great. So it's 8 o'clock, so we'll get started because we try and finish somewhere between 9:15 and 9:30, if that's okay. Thanks again for all your feedback. It is shaping what we're doing. We really appreciate it. Positive and negative feedback. We're thick-skinned, as you probably saw from my tweet this week. We had a pretty crushing tweet, but you know what? I'm still here, and I've still survived it. Today, the focus is going to be on knee. We've got osteoarthritis of the knee. We've got meniscal injuries of the knee, and we've got patellofemoral osteoarthritis, all of which are pretty common exam topics. Got three great speakers, Ben Coop and Simon Barton, my colleagues from Wrightington, and their superstar, Ted Yu, fellow who is now at Oswestry. Is that right? You're at Oswestry?
On 5th of August, I start.
On the 5th of August, he starts at Oswestry, so that's great. And congratulations on your job. That's fantastic news. And we've got Chris and Graham from boat. We really appreciate you supporting us with this joint venture. At some stage, we may consider taking a break for summer, but at the moment, people are quite keen to keep on the momentum, and I appreciate that. I may have difficulty. I'm driving next Sunday evening, so I'm going to get one of my colleagues, hopefully, to step in and do something next week. We've got great talks lined up. We've got pelvic trauma, all the basic science around massive hemorrhage. We've got pediatric orthopedics, pediatric hands. So there's plenty in the pipeline coming through. So with no further ado, I'm going to hand over now to Ben Coop, one of my knee colleagues. So Ben, if you want to share your screen.
Okay. Right. Thanks very much, Mike. Thanks very much for inviting me. I heard quite a lot about this program, so I'm hopefully going to contribute. Tried to give a whistle-stop tour through how I manage early knee arthritis, which is a large part of my practice in knee preservation. I'm hardly going to talk about total knee replacement. It's pretty dull, and I've not got a great interest in it. It's a very, very easy topic to ask as an examiner, and I always ask it when I'm doing the Wrightington FRCS prep courses, and it's really interesting to see how tangled people get in their answers. Okay, just going to talk about a few pointers in identifying OA. Might sound really easy, but there's some things that are done badly, and when you're asking a simple question, you need to be able to answer it concisely. So identifying OA. Early OA is easy to identify clinically. You're looking for symptoms of pain, stiffness, swelling, loss of function, and they're typically activity related. Stiffness is worse after rest. Patients often describe it as seizing up, but it's not more than about 30 minutes. It's the kind of thing that first few steps are sore, but when I'm going, I'm fine. Early morning stiffness is more a sign of inflammatory arthropathy, but it persists more than about half an hour. Signs in clinic: patient will limp in, got a swollen knee, they've got a stiff knee, loss of range of movement, and they've got deformity. Now, that might be coronal plane deformity, varus or valgus, or they might have a fixed flexion deformity, and they may have palpable osteophytes. All these things are pointers that really it's arthritis before you've even seen any imaging. How do we investigate? Your workhorse is the weight-bearing AP. This has got a grid on the back, in the background of it. It's one of our long leg films, which I've cropped. 90% of the time, this is the one that we're looking at, making our diagnosis about severity radiologically. Kellgren-Lawrence grading is the one I use. I think it's reasonable to ask you to be able to grade a weight-bearing AP. These are the written definitions, but if you have tabulated it in case it's helpful, 0 is normal, and you see osteophyte, joint space narrowing, sclerosis, and bony deformity gradually creep in as you get down to grade 4, where you've got multiple large osteophytes, marked joint space narrowing, marked sclerosis, and definite bony deformity. The majority of cases that get knee replacements really should be grade 4, and in fact the majority of ones that have major surgery, whether it's total knee replacement or something else, in the UK tend to be grade 4. There's a few 3s creep in, but the rest don't. Other plane imaging, laterals are useful. Skyline views, yeah, take it or leave it really. That's personal preference. A lot of it depends on whether your unit is used to taking a good skyline view. A lot of the time it's just a wasted X-ray. And the Rosenberg, which is illustrated on the right here, X-ray B, is useful for picking up earlier OA. You can see, one might think on the X-ray on the left that there's relatively well preserved joint space, but in fact there's bone-on-bone arthritis. And the reason that the Rosenberg works, which is 20-degree flexed X-ray, is that it brings the most worn parts into contact. MRI is useful. I use it a lot, particularly because I'm looking for distribution of wear between the 3 different compartments. This is a fairly typical MRI of a worn medial compartment. You can see that the chondral surface peters away as you get towards the medial edge. You have osteophyte on the tibia, osteophyte on the femur. The medial meniscus is extruded and it's lost its nice black signal, so it's torn as well. There's bone edema. All of these are signs of a failing compartment. Okay, arthroscopy. Shouldn't be using arthroscopy to identify OA. Should have picked it up from the imaging, should have picked it up clinically. If you're looking inside a knee and going, oh, it's arthritic, you've done something wrong. The only time it is useful is when you're trying to delineate the wear very carefully, if you're thinking about joint preserving surgery, or maybe if there's a difficulty in deciding whether it's an isolated chondral defect amenable to cartilage stimulating procedures like microfracture, or whether it's a more diffuse lesion. Sometimes you can't tell the difference on MR. So the crux of it, how do we manage it? Well, with it being an incredibly common diagnosis, NICE have an awful lot of information about managing knee OA, and it's very easy, I would suggest, for an examiner to ask stuff that's in the public domain and that everybody should know. So diagnose someone with knee OA. The first step, simple measures. They've described it as holistic approach and self-management. This is basically giving the patient good advice. It's telling them what the diagnosis is. The patient maybe just easing off a little bit and doing things a bit differently. Followed by core treatments, which is a little bit more information about how to manage it better, some judicious exercise and advice about weight loss. If you're answering a question about how to manage medial OA, which is a dead straightforward question to ask, and the one I tend to ask given half a chance, I would always go to the nice default 5er option and say, well, there are non-operative and there are operative measures. Now, a lot of the time, the examiner is not really interested in what you do non-operatively, but I think it's fair to ask, and it really does pick the bad candidates out sometimes. So, basic treatments, advice. Lifestyle changes. Now, for some people, that's giving up work, working differently, retiring. It's not anticipating running 50 miles a week. It's different for different people. This is a discussion with a patient. Physiotherapy. Physio tends to be aerobic activity and it's muscle strengthening activity. It's not always your quads. Quads are important, but the abductor muscles around the hip are very important in leg positioning. And if they're not working properly, then the quads aren't going to work properly. So a good biomechanical assessment from a physiotherapy will benefit a proportion of patients quite significantly. Analgesia, first line is non-steroidals and paracetamol. NICE actually advise non-steroidals as topical management first, which is fair, I suppose, because it reduces the risk of side effects, but opiates are in the next tier, they're not first line. I tend to advise a lot of my patients to use poles, and that's walking poles, because they tend to be complaining, they're a little bit younger, they tend to be complaining they can't go out and do a long walk, can't get into the Lake District, they can't go out with the family and do what they used to do. So they're still fairly active, but they just need a little bit of something to keep them ticking over. Obviously, your older, frailer patients might need a stick, a crutch, or a frame. The bottom 3 are a little bit more interested in non-operative management, so I've just separated those slightly. In terms of orthotics, people do use lateral wedge insoles to try and alter the position of the foot and hope to correct some varus. There's very little evidence one way or the other on that, and the jury remains out. Certainly, I've had patients who have been prescribed it by somebody else, and they have found the wedges beneficial, but equally I've got patients who reported no difference. Unloader braces or offloader braces, there are meta-analyses out there that say that there's not enough evidence, and the Cochrane review is one of those. But a couple of years ago, there's a nice RCT looking against a placebo or sham brace, and that seemed to come up with a definite improvement. Not necessarily in the changing the adductor moment of the knee, which is what they claim to do, but actually definitely in reducing pain and symptoms. So I use offloader braces quite a lot, and I think they're worthwhile. Injections, a little bit of a vexed issue at the moment. There's a lot of interest in certain sectors for things that you can inject into the knee that might be really, really expensive. Steroid is our go-to and has been for many years. A few more concerns about steroid, about long-term damage. Some recent publications looking at degeneration of articular cartilage with multiple steroid injections. The suggestion maybe that 3 should be the limit, but it's a little bit arbitrary. I use steroids sparingly. I think it's a short-term thing. Average lifespan of a steroid injection is about 2 weeks. Obviously, there's some patients that get no response and some that get months and months of relief, and so it's worth a go if nobody's had one before. But I don't go out my way to offer it, really, to be honest. Hyaluronic acid was a big thing 10 years ago. It used to be 3 injections over 3 weeks, and it was heavily marketed. NICE do not support its use. The cost benefit analysis has come down heavily in favor of not using it. It's not that dear, it's just not that effective. I've never had a particularly good response from it with my patients. PRP is relatively new. There was an interesting small feasibility study, 15 patients in each arm, randomized between Arthrex's ACP, which is a version of PRP, and placebo, which was saline, and that showed a big effect for the PRP. So NICE will let you use PRP, but you must have special governance and audit arrangements about measuring outcome afterwards. You can't just slap it in willy-nilly in clinic and send the patients on their way. So it needs to be part of a structured program within the hospital. Stem cell therapies, I get a lot of inquiries from patients who read something in the Daily Mail, things like lipogems, which is abdominal fat spun down and bits of it injected in your knee. None of it has any clinical evidence yet. They have lab-based stuff and theoretical stuff, but nothing in humans. So the answer I will give to that is, it's very interesting, but it's not for use in patients as yet, apart from in research settings. Okay, arthroscopy. The important thing to note about the arthroscopy option for arthritis of the knee is that it has no role. Okay, the only role for arthroscopy is if there are marked mechanical symptoms or loose bodies, ideally proven on imaging. Mosley's paper in 2002 in the New England Journal was a landmark paper in changing the role of arthroscopy. Still get GPs asking, and occasionally trainees talking about, what about a washout? Absolutely no benefit, and I think that's become ingrained now in the knee community. So we have a treatment gap, and this is the problem. We have a lot of patients who maybe got mild to moderate OA, they've got symptoms, they're intrusive, they're infuriating, but there's no real treatment for them. They can't have an injection that lasts, they don't like taking pills, and the only options surgically really ahead of them are all major operations, and this is the problem. And that's why there's a lot of time is spent on conservative measures, counselling, providing orthotics, providing physiotherapy, till the patient essentially can't cope with the conservative management, is bad enough, and has come to terms with the fact they're going to have a big op to sort it out. There are, I would say, 3 operative options. Focal resurfacing, I've only put in to say that it exists. These are the little discs of metal or metal back plastic that you can stick in to cover a sizable chondral defect. There's a biopoly, there is the episealer, and there's another one that name escapes me at the moment. They're relatively early. Episealer, which is the newest and has the best data, is only got data out to about 2 years, so it's a watch and wait for focal resurfacing. So broadly, in my practice, there are three workhorse treatments. There's osteotomy, which is predominantly high tibial osteotomy because it's predominantly medial compartment OA. There's unicompartmental replacement, and then if push comes to shove, there's total knee replacement. I'm going to talk about osteotomy in principle only because it's a big topic, and most people don't come into contact with it. There are a few decisions to make when deciding if you're doing an osteotomy, what you're going to do. You're going to do it on the tibia or the femur. Is it going to be an open and closing wedge osteotomy? You can do it medially or laterally, and how you're going to fix it back together. So making the osteotomy depends on the deformity. Most of the time, it's medial tibial OA, and the deformity is a metaphyseal part of the tibia. It may be that that part's normal, and that all the deformity is intra-articular. I'd be a little bit more careful with that group of patients when deciding whether to go for osteotomy or uni, but it depends on other factors. The core concept is the center of rotational abnormality, and that's in the proximal tibia if you've got this type of patient. The MPTA is the medial proximal tibial angle, which is the one that's demonstrated on the image. So how we're going to make valgus for these patients, there's an option for medial opening wedge, lateral closing wedge, dome osteotomy, which I haven't seen, and I don't think it was ever particularly big in the UK. Broadly, it comes down to medial opening wedge, which is more fashionable at the moment, versus lateral closing wedge, which was fashionable 20 years ago. The medial opening wedge is a little bit more adjustable intraoperatively, although how you would decide to adjust it or not is debatable. It's probably a little bit safer. You're in easier territory. It's an easier conversion to total knee replacement later because it doesn't cause the translation of the shaft of the tibia under the plateau that the lateral closing wedges do. There is some data, some comparative data out there that suggests maybe they have a bit better earlier function. They're faster to weight bearing, although that might be to do with better fixation these days. On the downsides of the medial opening wedge, it can drag your patella down. It does give a feeling of lengthening to the patient in the bigger osteotomies, and maybe it increases the slope. That might be related to how you do it though. So that I would say that's debatable. The lateral closing wedges, the reason people have moved away from them is because you're messing around near the common peroneal nerve. You've got to do something to the fibula, either the tibiofibular joint, which can be disarticulated and allow the fibula essentially to migrate proximally, or you can do an osteotomy of the fibula and take a chunk out, but then the risk is pseudoarthrosis. Fixation options, they've come on a lot over the last few years. Plaster cast and staples are really out. Purdue plate was the first of the plating systems, but it had some problems with fracture in its original version. The Tomafix plate is the most commonly used at the moment. That's certainly what I use. It's very robust. There are some newer devices coming on the market. The things made out of PEEK that sit inside the osteotomy with the idea that it minimises metalwork removal. It's a developing field. The other couple of interesting or very slightly different things is external fixation, which certain centres use. There's an idea that it's adjustable and the patient can tell you when it feels right. Same for the extendable IM nail, which is a research thing at the moment, but it's essentially a growing nail, rather like the spinal growing rods, and it allows the osteotomy to be jacked out over time. How much valgus? So this is the image, or an image essentially copied from Fujisawa's paper. He described a point that was 1/3 of the way from the center towards the lateral edge. It's often misquoted as 62% of the way from the medial to the lateral edge. If you think about it, 1/3 of the way across from the center to the lateral side is actually 67% of the way across. So frequently misquoted. 62% is not Fujisawa's point. That was described by a chap called Frank Noyes. So these are my choices. I do a high tibial osteotomy most of the time because it's medial OA, usually medial opening wedge, Tomafix plate. I did correct to Fujisawa's point for a long time. Most of the time now I correct to 60 for various reasons, probably just fashion. So I put, just to reiterate, I put Fujisawa's point in in inverted commas. We all call it that. It's not. So who gets an HTO? It tends to be younger, active working men. So your 45-year-old builder with a trashed medial compartment, he's the guy. He might have had a rugby injury when he's younger. ACL's not been working, early onset OA. He's well motivated. He's got a busy, heavy job he wants to get back to. His disease is isolated to the medial compartment. And they've got to have deformity. They've got to be varus. Who don't I do? People with poor bone quality. So anything that impairs bone healing, like renal failure, smoking, definitely not anyone with inflammatory arthropathy. Definitely not if they've got significant lateral wear, but the location of the wear and the degree of the wear is important. In terms of smokers, there is an argument that you're denying treatment to people who smoke, and that is definitely true. The Tomafix literature originally had an absolute exclusion criteria that said, do not operate on patients who have nicotine abuse. So basically, it's the nicotine. They've removed that from the later documentation, but there is a definite risk of delayed or non-union smokers, and if you have wound breakdown, it's an absolute nightmare. Diabetics, similarly wary because of wound breakdown or infection problems. I will operate on diabetics if I have to, but that control has to be good. It would be an indication perhaps to do a uni knee instead. It would be a good option to do a uni instead. But sometimes you've got a 38-year-old with a varus knee, and he just happens to be diabetic. And in those cases, I'd go with an HTO probably. Subluxation isn't an issue, I don't think, unless it's gross. If it gets very significant, you start to get lateral wear where the condyle impinges on the lateral tibial spine, and that can rule it out. Patellofemoral OA, again, not a particular problem. I'd be a bit wary if it's lateral facet, though. You'll tend to offload the medial facet with an HTO, so you're dealing with them both at once. It's very common to have medial facet wear with medial compartment OA. Uni knee replacement. I'm not going to talk about everything with uni knee. I realise I've got to come to the end and somehow wrap up early knee OA in the next few minutes. There are a couple of things I want to point out though with uni knee. Patient selection is important, but there's a debate still whether they have better functional outcomes and whether they have worse revision rates. And it's not black and white, but you often get two opposing camps. I think it's important that you're able to discuss the issues. You can come down on one side, that's fine, but you've got to be able to back up your argument. So I'm a uni knee surgeon. I would say I'm not a rabid uni knee surgeon. I realize there are other options. The claims from the uni camp really are that it has better function, it has reduced risk, reduced length of stay, and it's an easier revision when the time comes. The TopCat study is a really good study. It's a big RCT, UK trial, multi-centre. It reported its 5-year results at the end of last year. It's well worth a read prior to the exam. The 1-year results obviously were published 4 years previous, and there's not a great deal of difference between the two. The other thing to look at, of course, are national registries. We've got data in the UK registry, but there's data in other international registries too. So TopCats, actually, these are 1-year results. It did show that there was a better Oxford knee score for the unis, and quite a few more patients said they'd have the op again. In terms of problems, there were fewer readmissions and a lower failure rate. And they decided they were going to determine failure rate by no improvement in knee pain or re-operation. So they were quite careful about how they chose that rather than just revision. On the downside, they decided pre-trial that the minimally clinically important difference was going to be about, I think it's 3. So the difference in Oxford knee score between the two groups was clinically insignificant. So the upshot from TopCat, just to go back to that for a second, was that initially there was there was a trend, but non-significant trend in better function for the uni knee group and increased patient satisfaction. Complication rates are a little bit lower, but broadly comparable. When they looked at the 5-year results, the surprise was that the revision rates were the same in both groups. Now, given the criticism that unis get for early problems, that was a surprise. And the conclusion they came to in the end was really based around the fact that there was lower complication rate, less time in hospital. And the conclusion was that from a health economics point of view, if a patient is suitable for a uni knee, they should be offered a uni knee first, which is a big thing to say, and it will probably influence policy over the next few years. National Joint Registry from New Zealand is interesting. They show, again, on this sort of did you like your operation kind of thing, rather than a more detailed score, they showed much improved patient satisfaction with uni knee. Reduced risk is definitely a thing. Medicare data from the States shows a lower length of stay, much reduced complication rate, and more patients going home rather than to some rehab facility. They try and get patients through there because of the way things are funded, so they often discharge quite a lot to rehab. So reduced risk, reduced length of stay, we can say that for certain. Is it an easy revision? Well, one of our colleagues at Wrightington, Henry Wynne Jones, did some work when he was an East Anglian trainee at a hospital he and I both worked at in Norwich. They had a big population of uni revisions. They had a very early, very keen uni knee surgeon who worked for many years there. They found that a lot of the time you're revising to primary components, probably about 2/3 of the time, which is pretty good. So if you can have a primary knee without any stems or augments 2/3 of the time, that's definitely an easier revision than a total knee. However, you tend to have a thicker poly, and they're not all like that. So yes, it's maybe an easier revision, but not all the time. The total knee group would say, well, hang on, that's all very well, but just look at the figures in their joint registry, and there is an argument there. So this is from the NJR from 2018. This is all uni knees that were available at the time, and this is the one I use. And you might look at that and go, what are you doing? Your revision rate for your Oxford knee is 11.5% at 10 years. Compare that to the total knee that I use, which is 2 2/3% at 10 years. It's not really even comparable. If you look at the best one on the NGR, it's the Zuck by a mile at that stage, and the revision rate is not a million miles away from total knees, in some of the other total knees anyway. Interesting when you look at the reasons for revision. There's a lot who revise for pain, about nearly 3%, and some for other indications. That does include advancing arthritis, but there's some where it's just not really documented. And the argument is that unis often get revised when you wouldn't revise a total. So if you look at this is again New Zealand Joint Registry, revision of uni knees, the Oxford knee score at 6 months, if it's less than 20, there's a 60% chance you get your revision if it's a uni that's in there. If there's a total in, there's only a 10% chance someone's going to revise it, and that's for the same Oxford knee score. So there is definitely a threshold problem, or a threshold difference. It may not be a problem. Doesn't necessarily mean your painful knee gets better. There's also a disparity in the literature when looking at 10-year data on the uni knees, systematic reviews of cohort studies, say 93% survival at 10 years. Oxford have published 94, Swedish study 94%. The NGR says 89%. And this is where all the GIRFT stuff has come in. So the Get It Right First Time program, very much concentrated on unis. This is important for the exam. The revision rate drops as your experience increases. So if you're doing about 40% to 50, 60% of your knee arthroplasties are unis, your revision rate is not too dissimilar from total knee replacement ones. Having said that, the most frequent number of unis done by a knee surgeon in the UK is 1 per year. It's still the biggest group doing 1 a year. The next biggest group is 2 a year, and this is where we have a problem. So GIRFT would suggest that there are 1 or 2 people in the department should offer uni knee. Everyone should be aware of it, and they should refer to their colleagues that do them regularly. Patient selection. Well, there's an argument for the younger patient. As always, you're trying to preserve the knee, but the older patients have lower morbidity with this operation. So maybe the older, sicker patient should be getting this too. Really, anybody at any age could have it. It needs to be isolated medial OA. I prefer the pain to be medial and focal. The deformity needs to be correctable, and knee needs to be stable. I don't tend to do patients with global pain. You can't do them if the varus is uncorrectable, and that's correctable back to physiological normal. If the fixed flexion deformity is more than 10 degrees, that's a no-go because you can't correct that. Similar with osteotomy. If their ACL isn't there, traditionally we've said, can't do it, uni's out. However, there's recent data suggesting that if it's attrition loss and the knee is still stable, you can still go on and do a uni knee, whether mobile or fixed bearing. MCL laxity is a problem for the mobile bearings, which like I use, and inflammatory arthritis is a problem. The worst thing in the world is doing a uni knee, patient coming back with problems, and then getting a diagnosis of rheumatoid. Absolute nightmare. So for the exam, I would say, in summary, you need to be able to reel off the conservative treatment and make it sound like this is what I do in clinic every day. You need to be able to back it up. If they say, well, why do you inject steroid? Or what about something else? You need to be able to argue it. If they say, well, what about weight loss? Does it really work? Yes, it does. There's a dose-related response. The more weight you lose, the better your knee pain. There's evidence to support that. You mustn't talk about arthroscopy as a treatment for arthritis. That's been out the window nearly 20 years. And when it comes to choosing HGO versus uni versus total knee, understand the principles of osteotomy. There aren't that many osteotomy surgeons around, so there's not going to be an expectation that you know how to do it necessarily. You need to be able to select the patients and need to understand the principles. With uni knee, I think it's reasonable to expect you to be able to discuss girth and the impact that has on arthroplasty. I'll leave these up while we move on, just for people to have a little look at how I tend to stratify people into each of the three operative groups. It's a sort of personal algorithm that I've just come to over time. Thank you. Mike, if I stop sharing, do you want to...
just let everyone just give them a second to screen grab that. Usually people just screen grab it, and just give a couple more seconds for you to screen grab it, because I think that's really, really useful. Thanks, Ben. That was excellent. Next speaker is Ed. If you could share the screen, that would be great. And thanks to both Ted and Simon for answering those questions. There was just one that I answered. We've had 1.5 hours of CPD approved for these by the Royal College of Surgeons, so we're very grateful to them for that. Afterwards, you get an email to say that you were in the webinar and you received it. I'm sorry if you're on YouTube live, you know, I don't know whether you saw it or not, but you might just want to take a screen grab yourself of watching it and try and get your appraiser to believe you watched the whole thing. Anyway, so no further ado, here's Ed. He's going to talk to us about meniscus.
Hi, evening. I'm the currently fellow working at Wrightington Hospital, and I'm going to talk about the meniscus. It's a brief talk, but I thought I'd cover the basic sciences and also of lesions of the meniscus. Having done the exam recently in the past few years, one of the basic sciences stations was actually on the meniscus. So I'll just move on to the next slide. They showed me an arthroscopy picture of the meniscus and asked me to talk about it, and led me down the line of talking about its structure and function. So going on to the ultrastructure, 70% of the meniscus is water. And one of the distinguishing things that from other types of cartilage is that 90% of the collagen is type 1. And this makes up about 60 to 70% of the dry weight of the meniscus. Other components in the meniscus include non-collagenous proteins, elastin, and proteoglycans. And they also contain fibrochondrocytes, which synthesize and maintain the extracellular matrix. Two types of cells, the fusiform cells in the superficial layer, and also the ovoid cells, which are found in the surface and the middle layers. So the collagen fibers, they asked me to talk about that. This is arranged in 3 layers, and they're named the superficial, surface, and deep. And the 2 main types of fibers in the meniscus were the circumferential fibers, which are found in all 3 layers, but mainly in the deep layer. And this is ideal for transferring compressive loads into circumferential hoop stresses within the knee joint. And then you've got your radial fibers, which are found in the surface and superficial layer. And these act as ties and provide structure against compressive forces and prevent longitudinal splitting of the meniscus. This is relevant because the predominant fibers are circumferential. It explains why probably your longitudinal or your vertical repairs are stronger than your horizontal ones for meniscal repairs. So there's a diagram of what I just said. So predominantly the fiber running in the deep layer, and then you've got your radial fibers running throughout. So the 5 functions of the meniscus: to transmit load through the knee. It provides stability to the knee, and which is why there's probably an increased association of ACL re-ruptures with meniscal tears, which are missed. They enhance articular conformity, and they distribute the synovial fluid across the articular surface. And also they provide proprioception to the patient. And it was Fairbanks in 1948 who associated total meniscectomy with accelerated joint degeneration. And more recently, there's a vogue towards meniscal repair over your total meniscectomies or even partial meniscectomies. So meniscal tears, you can talk about them into a location, either in the red zone, which is right at the periphery, the red-white zone in the middle, or the white-white zone right at the rim. And why this is important is that meniscal tears occurring at the red zone are more likely to heal if repaired. And so this would alter your surgical management once they're diagnosed. And then you can also talk about meniscal tears in terms of the type of tear it is. So your longitudinal tears, your radial tears, which go in line with your radial fibers, and your oblique or paraoblique tears. And a combination of all of those can give you complex tears, which are often not repairable. And it's your longitudinal tears which give you bucket handle tears. So management of meniscal injuries, obviously always start off with a thorough history, examination and imaging. The bare minimum, obviously an X-ray and normally an MRI as well. And what you're trying to identify is that their symptoms are coming from a meniscal tear, but more importantly, whether the patient has changes of osteoarthritis. And the BASC recently published guidelines on the surgical management of meniscal tears, which have become increasingly relevant, especially in many areas. Arthroscopy is deemed a procedure of low clinical value. So possible scenarios that you would encounter with a patient with meniscal injury is a locked knee, and these do indicate urgent arthroscopic meniscal surgery, whether this is a repair, if it's repairable, or a meniscectomy. If the patient has advanced structural osteoarthritis as diagnosed either on the MRI or on the X-rays, then no surgery for these patients are indicated. If the patient presents with an acute injury with a meniscal target, then you could consider arthroscopic repair for these patients if the patient was a surgical candidate, obviously. The other two scenarios, if the patient has a meniscal target with symptoms and signs, what you're trying to do is elicit how long the symptoms have been there for. And many of these patients would benefit from a trial of non-surgical treatment. So if the symptoms are new and have been present for less than 3 months, it's perfectly reasonable to go down the route of non-operative treatment in the form of good quality physiotherapy, exercise, analgesia, and maybe even a steroid injection. However, if the symptoms have been present for more than 3 months and non-operative treatments haven't really worked, then it's reasonable to consider a non-urgent partial meniscectomy. If the patient has a possible meniscal target with possible symptoms and signs, then the advice would be non-operative treatment for these patients. Now, the ESCA team have also carried out a meniscus consensus project, and their work is more focused towards the degenerative meniscal lesion. So it was slightly different to the guidelines provided by BASC. And your degenerative meniscal lesions are normally slowly developing lesions. They're typically horizontal cleavage in nature, and they generally occur in the middle-aged or older patient. And they say middle age is anything 35 or over. And there's often no clear history of an acute knee injury, or the patient may associate it with something very trivial, such as getting out of a chair. Now, they're very prevalent, degenerative meniscal lesions, 25% in your 50s, 35% in your 60s, and 45% in your 70s. And in the presence of knee OA, you're looking at between 75 to 95% prevalence of a degenerative meniscal lesion. And there's very limited evidence that pain in the degenerative knee is directly caused by your degenerative meniscus, which is why arthroscopic surgery for the meniscus is unlikely to provide any benefit. And again, going back to what Ben Cooper's been talking about, there is no role for arthroscopic washouts in such patients. So the ESCA have devised a very simple algorithm to treat these lesions. And in a patient with a non-locked painful knee for a month or more, in a patient of over 35, and with a history and examination consistent with a degenerative meniscal lesion, then non-operative treatment is advised. You can get x-rays, however, an MRI is usually unnecessary in these patients. And they do again recommend injections as a possibility. And you should really go down this route for at least 3 months since the onset of symptoms. Unless, as always, if there are exceptional cases if the patient has considerable mechanical symptoms. If the treatment fails, then it would be reasonable to obtain an MRI, and only if the patient doesn't have evidence of OA, only then would it be reasonable to perform a partial meniscectomy. However, again, if there's evidence of advanced OA, then there is no role for arthroscopic debridement unless the patient has considerable mechanical symptoms such as intermittent locking or catching, which is debilitating. And that's it, a very short talk. Thank you.
Thanks, Ted. That's great. And we'll head on now to Simon, who's going to talk about patellofemoral problems. And again, thanks for answering all the Q&As as we've gone along. So Simon, that's great.
Right, 1 second. Right, evening. So I've been given the small task of discussing patellofemoral instability in 15 minutes. So we'll just start with some of the simple basics, and really I don't think there's enough time to do a complete deep dive into patellofemoral pathology. So I've tried to focus on some practical bits and pieces in terms of the diagnostic algorithm and appraisal of imaging, which I hope will try and demystify many of the things that put people off individuals or patients that have got recurrent instability. So it's very prevalent. It is in fact patellar dislocations are the second most common cause of a hemarthrosis presenting to an orthopedic surgeon. In the teenage age group, 10 to 17-year-olds, it really has got quite a high incidence. And similar really to some of the numbers that you may hear with ankle fractures, first-time patellar dislocator, many of them will have a high risk of recurrence, so up to 44%. And interestingly, over 50% of patients will report not returning to the same level of sport after a primary dislocation. So that's, quite an interesting fact. In terms of the immediate management for an acute patellar dislocation, most will spontaneously reduce due to the activation of the quadricep muscles. But if you do get a patient presenting who hasn't had their patella reduced at the scene of the injury, just appropriate analgesia, bring the knee into extension should allow the patella to drop back in. Bracing is something that really have to be guided by your local management. Many of us are now working through a virtual fracture clinic setup, and this is empowering emergency departments to discharge many patients with acute knee injuries without discussing with an orthopedic specialist in the hospital. And therefore, many departments have felt it's safest for people to go into a cricket pad splint, because that will reduce the chance of missed medial collateral ligament injury or other such injuries. But it's most important that a patellar dislocation isn't splinted in extension. Long gone are the days when we would immobilize someone for 8 weeks. It's just a catastrophic approach. So a brace is acceptable, but it really needs to be taken off early, and the patient needs to be reviewed by a knee specialist and assessed. X-rays, including a skyline, as you can see here, the avulsion most likely of the MPFL, and then early physiotherapy is very important. It's very rare that there's a large osteochondral fragment that requires emergent surgery, and therefore the early phase of the rehabilitation is to get the soft tissue swelling down, get the range of movement going, and quads reactivation. Many of them will have significant quadriceps inhibition due to the pain that they're experiencing. And then seen by a knee specialist. And as a knee specialist, I would always get an MRI. And I think if you think about the risk of recurrence and the associated chondral injuries that you may find aren't well appreciated on plain imaging, an MRI is essential. So whenever we're talking about patellofemoral instability, everything relates back to the pathoanatomy. The main things that we know influence patellar stability are the trochlear shape and depth, the patellar height, the medial retinaculum, and then less relevant in the modern era of patellofemoral instability and less prevalent in clinical practice is the sort of miserable malalignment, significant malrotation of the tibial tuberosity, and rotational profile abnormalities. You should always assess for hyperlaxity and do a Baton score, but in real terms, this doesn't often significantly impact on your management algorithm. So when trying to define normal, there are a myriad of different ways of assessing, measuring, and determining patellofemoral anatomy. Trochlear sulcus angle is one that most people find quite straightforward, but the problem with that is it's very much dependent on whereabouts you're measuring that knee in the flexion arc, whether it be on MRI or on X-ray. Lateral trochlear inclination is a line defined by the lateral sulcus and the posterior condyle. But more importantly, now and in modern times, is looking at the patellar trochlear cartilage overlap. And I think I'll go into it in more detail in the talk, but really it's about understanding the functional anatomy of the patellofemoral joint. So everyone is aware of the de jure classification. This is, a very well described classification from both Henry and David de Jure, father and son. The issue that has always been laid at the feet of the disorder classification is that while it was originally described and proposed that it helped to define surgical management strategies, I think many of us who treat patellofemoral pathology would agree that it's in some way overly complex and actually doesn't really describe the pathology that's seen day to day. So pragmatically now, most patellofemoral surgeons will assess a trochlea as either being normal, flat, or severely dysplastic. And severely dysplastic, by and large, is convex or domed. And in some instances, you will have an even more severe lateral facing trochlea. So I think that sort of simplification does help to determine our surgical strategy thereafter. So patellar height, this is a classical exam question, but unfortunately, in real terms, while it's nice to be able to mention these three indices, they were all originally described on plain radiographs, and obviously now the majority of our assessment of the patellofemoral joint is to do with the cartilage, both the patella and the trochlear cartilage, its shape, and therefore basing your assessment of patellar height on the bony anatomy is quite outdated. So in terms of assessing patellar alta now, what we're really looking at is assessing the patellar trochlear cartilage overlap. So this is an MRI-based assessment. There are issues with it. Ideally, it would be mid-sagittal, but a mid-sagittal scan often doesn't give you a full appreciation of where the patella is sitting in relation to the central portion of a dysplastic trochlear. Anyway, that aside, the BEDA patellar trochlear cartilage index is the modern standard for assessing patellar trochlear overlap, and it's quite simply the length of the patellar cartilage divided by the overlap of that with the trochlear cartilage. And alta would be anything below 15 or 20%. So this MR scan on the right has a patellar trochlear cartilage overlap of around about 7%, so that's significantly high. As mentioned, this isn't a perfect science, so it assumes that the trochlea that's being measured is actually a groove, and it may well be that that's a dome, and therefore that's not a functional trochlea that's going to provide any anatomical stability to that patella. In chronic subluxation, severe dysplasia, it's an inaccurate way of assessing it. And obviously, if you've got a very painful knee and the knee is flexed for comfort in the scanner, that's going to have drawn the patella down into the groove further, and therefore will affect the way that the measurement's interpreted. So there is no perfect gold standard for this just now, but the way that I like to think of patellar alta is in terms of an instability arc. So if you think the patella doesn't engage with the trochlea in normal anatomy until around 20-25 degrees of knee flexion, if your patella is high, you've got much more flexion where it is unstable and not conformed by the anatomy. So when we're assessing patellar height, you really have to think about not only the anatomical resting position of the patella, but the morphology of the patella cartilage, whether it's got a long beaked nose and a high cartilaginous surface, whether the trochlea is dysplastic, domed, or flat. And then if the patient can hyperextend, that's going to increase their instability arc. And obviously, once again, when you're lying supine in an MRI scanner, your quadriceps aren't active at all, and that can once again affect the patellar height quite significantly. So in terms of a modern gold standard for assessing patellar height, in my hands, that would be a dynamic clinical assessment, MRI imaging, and then an arthroscopic assessment through a supralateral portal. In terms of the retinaculum, most people are well aware of the MPFL. It's one of the most populous operations that have been performed over the last 10 years for patellofemoral instability, and with good results. we have come to understand the anatomy of the retinacular structures increasingly over the last 10 years as well. MPFL remains the primary restraint to lateral translation, and as mentioned, that's up to 20 to 30 degrees of flexion. It's 5.5 centimeters long, 15 millimeters wide. It has a tensile strength of about 208 newtons. So what's the relevance of that? Well, if you think a gracilis tendon that you'd use as part of an ACL reconstruction, when doubled, has a strength of nearly 900 newtons, you can see that almost all of the soft tissue structures that we use to reconstruct the MPFL are significantly more stronger than the native ligament itself. And therefore, it's really imperative that these aren't over-tensioned when reconstructing. So in terms of the insertion, simplistic terms, it inserts at the proximal and the junction of the proximal and middle third of the patella. And the femoral insertion, simplistically, is 2 millimeters anterior and 4 millimeters distal to the adductor tubercle, which, whenever talking about ligament reconstructions, is the sort of lighthouse of the medial side of the knee. But you can see from this table that there are significant other contributors to the retinacular structures, including the medial patellatibial ligament, the patellomeniscal ligament, the transverse fibers of the medial retinaculum, and most importantly, the lateral retinaculum. So I think, many people will have unfortunately seen a lateral release as a procedure to aid with patellofemoral stability, but actually it's an illogical approach. It actually destabilizes the patella and can make things much worse. I think one way of thinking about it is if you're riding a horse and you release one of the reins, there's no way that you can get any significant tension in the other rein because the horse is just going to veer one side. So it's similar. If you take away that lateral restraint, then it's difficult for the medial structures to have their normal tension. There is also some resistance of the lateral retinaculum as it envelops over the lateral trochlear ridge, and that gives some stability to the patella as well. So in terms of the femoral insertion of the MPFL, you may or may not have heard of Schottler's point, a famous surgeon in Europe who popularized this insertion point. There has been some more recent work from a group in London that have shown that maybe Schottler had got it a little bit too anterior and proximal. But fundamentally, I think if you're using X-ray and you're aiming in this region, just distal and anterior to the adductor tubercle, you're going to be in a safe spot. So additional investigations, as mentioned, miserable malalignment in terms of its frequency as a combined pathology with patellar instability. It still represents a very small proportion of patients that present with patellar instability. Many of them don't have significant valgus alignment. It's obviously very important that you do pick it up and it's assessed through long leg alignment views. And equally, if you pick up gross rotational abnormality, you do need to get a CT scan because any knee-based surgery will probably fail if you've got significant rotational profile abnormality. The tibial tubercle trochlear groove measurement has been very, very popular for trying to inform the way that a tibial tubercle osteotomy might be performed. The problem is that if you've got a grossly dysplastic trochlea, then how can you possibly manage the TTTG? It just sort of doesn't really make sense. And I think the current focus for surgeons treating patellofemoral pathology is actually correct patellar height, and that's going to be the most rewarding profile of surgery. So trying to simplify things further, if you see someone with recurrent instability, a clinical examination, X-ray and MRI, if they've got no significant rotational or alignment profile abnormality and normal bony anatomy, simplistically, an MPFL reconstruction will be a good surgery for them. If they've got a high riding patella, a tibial tubercle osteotomy and distalization plus an MPFL will be appropriate. And if they've got dysplasia, you can then try to classify it into mild or moderate, which would be flat, or severe, which is convex or lateral facing trochlea. And that will then determine whether or not you need to do a trochleoplasty. So just some simple tips and tricks. MPFL surgery, as I was alluding to before, the ligaments that we use to reconstruct the MPFL are very much stronger than the native ligament itself, and therefore it's important that you don't overtension the MPFL. If you flex the knee up to about 45 degrees and then fix the MPFL in that position, it will be contained within the trochlea and therefore will not allow you to overtension the structure, which is very important. I think when you're starting out and learning how to do this procedure, the best thing to do is to try and palpate your femoral insertion and then place your guide pin or Beath pin on that point and get a check x-ray. You may find that after you've done 50 that you're very reliably hitting the right spot, but even experienced surgeons will continue to use radiographic assistance in obese patients. The other thing to say is that with people with significant dysplasia, it's often more important probably to check the isometry of the graft rather than be particularly worried about the exact anatomy of the insertion, because the isometry may be different based on their dysplasia. Intraoperatively, if you flex the knee and the graft is tight, then you've probably got it too proximal, and if it's too loose as you flex the knee, it's probably too distal. So the high and tight, low and loose is a little thing to remember intraoperatively if you're struggling to work out where you need to move your guide pin or your femoral insertion. In terms of tibial tubercle osteotomy surgery, traditionally things like the Fulkerson were always done with the osteotomy started medially, but actually the lateral face of the tibia is flat, and it therefore gives you a very, very easy surface to rest your saw or osteotome upon, and makes it a much more reliable and relaxing surgery to perform. When you're trying to mobilize the osteotomy, if you do release the medial patellofemoral ligament, you'll find that the osteotomy fragment is very free and easy to move and distalize. And as mentioned before, medialization has sort of fallen out of favor, primarily because it does lead to overload of the medial facet patella and significant osteoarthritis later on down the line. So simple distalization for patella alta is extremely effective. If you're fixing with a couple of screws, you should aim them from proximal to distal, as this has been shown to be biomechanically advantageous, or as we've started doing, using a little 1/3 tubular plate to cross the osteotomy and reduce the risk of displacement. Trochleoplasty is absolutely essential for patients with severe dysplasia. So if there isn't a surgeon in your institution that performs trochleoplasty, it's very important these patients aren't treated with a tubercle osteotomy and MPFL, because it will more than likely fail or result in significant arthritis later on. So I just thought I'd try and show a couple of cases to highlight some of the points that I was making earlier about how scanning is important, but can also be very difficult to interpret. So the picture on the left, well, this is actually a left and a right knee from the same patient, but you can see that in chronic subluxation, or in this case a lateral facing trochlea, on the mid-sagittal slice you can't see the patella at all, so how can you possibly judge whether or not they've got alta? Equally on this side, you've got a little view of the patella here, and you can see that there's virtually no patella-trochlear cartilage overlap. So that's a sort of good evidence of how severe dysplasia can significantly impact on your ability to measure these indices. So another example, another very high patella, but interestingly, if you do the Caton de Champ, her measurement falls into the normal range, whereas if you do the patella-trochlear cartilage index, you can see that it's definitely abnormal. And I think if you were to look at that radiograph and to feel that knee, you'd know that the patella was very high. So it just shows that it's important to look at and appreciate the cartilage overlap as the primary way of assessing patella height. In terms of where to assess trochlear morphology, as I was talking about before, if you measure the trochlear depth as you get towards the notch, it will appear normal. This individual's obviously got a grossly dysplastic trochlea, evidence of a recent dislocation with a lateral femoral condyle bone bruise. But as we come further down, although there's no patella in this groove, you can see that you could make an argument for the fact that they have a groove. So it's very important that you're experienced looking at the scans, you're an experienced radiologist that can review them, and that you do measure things appropriately. And then down to clinical case, and you can see gross patellar instability. This is chronic, long-term. But once again, the skyline on the X-ray shows the patella is chronically subluxed, but there's a groove there. There's certainly no groove on the MRI, and this patient was treated with a trochleoplasty and a significant distalization and a medial soft tissue reefing to help stabilize the knee. So that's sort of the end of the talk. I hope that was in some way informative. I think it's quite a complicated topic. And I think for the exam, I think just trying to think in simplistic terms about the assessment and then having some simple ways of describing X-rays is very helpful. But fundamentally, the most important things are trochlear dysplasia, patellar alta, and then retinacular structures. Thanks very much.
That's great, Simon. Thanks very much. And thanks to the other panelists as well for their great talks. And also, I think that's the highest number of questions that have been answered, 34 questions that have been asked throughout that. So I think what we'll probably do is we've got 20 MCQs, so we'll go straight to those, I think. And then the panelists, if you wrote the MCQ, maybe you read it out, give the attendees time to read it, write it down on a piece of paper, or they answer them as they go along. Go through each question reading so the people on YouTube Live can hear it, because I'm not sure they can always see them. Once they've gone through all sort of 10, or at the end of the poll, give them a minute or so. We then release the answers of what the answer spread is, and then each of the panelists explain which was the correct answer. So there's only one answer that's correct on these. So if I launch poll number 1, this is about osteoarthritis and meniscuses now. So, so perhaps Ed, I think these first 5 were perhaps yours. Do you want to start to read some of those out?
So question 1, the interaction between water and hyaline cartilage is beneficial because A, cartilage repels water. B, water is absorbed by cartilage. C, water lubricates the joint. Or D, water is imbibed in the cartilage and therefore has a passive role in resisting compression. Question 2, which of the following investigations is the most specific scanning method to detect infection in a total joint replacement? Bone scintigraphy, a combination of white blood cell scan and a technetium bone scan, white blood cell scan alone, sequential gallium-67 citrate scans, or sequential technetium bone scans. Question 3, what proportion of patients will develop significant back or ipsilateral knee pain 25 years after arthrodesis of their hip joint? 0%, 10%, 45%, 60%, or 75%. Question 4, which of the following is not a cause for failed anterior cruciate ligament reconstruction? So not a cause. Associated posterolateral corner injury, cyclops lesion impingement, tibial tunnel placement 10 to 11 millimeters anterior to the posterior cruciate ligament insertion, arthrofibrosis of your graft, or returning to full sporting activities at 3 months. And question 5, a young athlete undergoes arthroscopy for an isolated meniscal tear. The surgeon performs a meniscal repair. Which one of the following factors is most important in determining the rate of healing? Is it the days from injury to repair, whether it's the medial versus the lateral meniscus, the width of the meniscal rim, the use of growth hormone, or whether the injury was in the dominant versus your non-dominant leg? So that's the end of my 5.
Okay, so I think, Ben, are these yours now? Ben, can you
Unmute.
Yeah, number 6.
Yeah, great.
What is the upper limit of fixed flexion deformity in which a unicompartmental knee replacement should be considered? Do they require full extension? Can they have 5 degrees of fixed flexion? Is 10 degrees the upper limit of fixed flexion, 20 degrees, or does it not matter? Number 7. Which unicompartmental knee replacement has the lowest 10-year revision rate as per the UK National Joint Registry? And the reason I included this question is if you're taking the FRCS in the UK and you are going to use a uni, the question will be, if it's not this implant, why on earth are you not using this implant? And you'll need to be able to defend yourself. Is it the Oxford, the Corin Uniglide, the Zuck, the Sigma Partial from Depew, or is it the old Miller Galanti? Number 8, what's the leading indication for revision of unicompartmental knee replacement in the NGR last year? Is it aseptic loosening, bearing dislocation, pain, infection, or is it progressive arthritis? Number 9, in osteotomy surgery, Fujisawa's point is how far across the tibial plateau from medial to lateral? 50%, 55%, 62%, 67%, or 75%? And number 10, which of the following may be part of a degenerate medial compartment in the knee? Extrusion of the medial meniscus, thinning of the articular cartilage, degenerate tearing of the medial meniscus, bone edema, or all of the above? That's mine, I think.
That's great. So the attendees now just read through those. Just MCQ practice. If ever it says all of the above, it's almost always the right answer. And if you've got a posh word like imbride, I'd always go for that as well. And oxygen-free radicals, that's always true. That causes everything, I think.
If in doubt, option C.
Oxygen-free radicals. And then if something's, whether it's genetically inherited or not, I always used to say it's autosomal dominant with variable penetration. I always thought that was really, really great. That always, the examiner used to kind of look at you and, you know, they didn't know whether you'd done an MD in genetics or something like that. But you've got to look at them really steely face when you speak to them. You know, there's no, you can't show any weakness. You've got to look right in their eyes. Variable penetration. So 69% of people have voted so far. So we'll just let that stabilize out a little bit. Quite often people don't want to vote, which is absolutely fine. I think we're pretty stable now. So what we'll do is we'll end the poll, and this will now show the spread of answers. So just perhaps we're a little bit short on time, so just perhaps read, you know, the salient features of each question. Ted, you do your 5.
Okay. So first question, the interaction between cartilage and water is beneficial because, and Mr. Hayton was right, if the answer has a complex word like imbibed, that's generally the right answer. So its answer was D, water is imbibed by cartilage and has a passive role in resisting compression. So water shifts in and out of the cartilage to allow deformation of the cartilage in response to stress. Water makes up 65 to 80% of the wet weight of hyaline cartilage, and in OA this can rise to 90%, but in very severe OA the percentage of water can be reduced. Okay, second question, was that the, sorry, I've lost, they're not on my screen anymore. Is that the
which of the following investigations is the, oh sorry, I haven't shared the results. That's not very good. Right, there you go, I'm sharing your results.
Yep. So yep,
everyone got it right. Question number 1. Apologies for that. Yeah. Question
2, which of the following investigations is the most specific scanning method to detect infection in a total joint replacement? So the majority got it right, which was B, a combination of white blood cell scan and a technetium bone scan. There's no single preoperative investigation that can reliably always diagnose a prosthetic joint infection. And your diagnosis is reliant on a thorough history and clinical examination, as with all cases. Obviously, you need x-rays, blood tests, aspiration of the joint, and the use of specialized imaging. But in 2010, a working group from the American Academy of Orthopedic Surgeons released a guideline and an evidence report, and this gave recommendations for the management of prosthetic joint infections. One of the recommendations was that nuclear imaging is an option in patients in whom diagnosis of periprosthetic joint infection has not been established and are not scheduled for reoperation. A combination of white blood cell scan and a technetium bone scan is the most specific scanning method. Okay, question 3. What proportion of patients will develop significant back or ipsilateral knee pain 25 years after arthrodesis of their hip? And the answer is D, 60%. And this was from a paper by Callahan, who performed a retrospective study into the long-term outcomes of patients with hip arthrodesis. 60% of the patients had pain in the ipsilateral knee with an average time to onset of 25 years. And a similar percentage had back pain. Pain in the contralateral hip occurred in about 25% of those patients. And then next question, which of the following is not a cause for failed anterior cruciate ligament reconstructions? Most of you hate these questions because they're the ones you're looking for a negative answer to, and they're easy to mistake. But the answer was tibial tunnel placement, 10 to 11 millimeters anterior to the PCL insertion. And that's because Hutchinson and Bay showed that the anterior border of the PCL was consistently 10.9 millimeters posterior to the central sagittal insertion point of the ACL in a cadaveric study. So in fact, that position is the best place for your ACL reconstruction. And finally, a young athlete undergoes arthroscopy for an isolated meniscal tear. The surgeon performs a meniscal repair. Which one of the following factors is most important in determining the rate of healing? Let's bring up that answer. And the answer was C, width of the meniscal rim. 80 to 90% success rates have been reported, and it's generally accepted that the success of the repair depends on the location of the meniscal tear. The type of tear and also the chronicity, however, are also important. Results are therefore best with acute peripheral tears in young patients who also have an ACL reconstruction at the same time. And the vascular supply of the meniscus is the main determinant of healing potential. So what we talked about was back in the red zone. And this is highest for tears in the peripheral third of the meniscus. Thank you. That's the end of my 5 questions.
That's great. Thanks, Ed.
Okay. So hopefully all my questions with my talk, maybe apart from one which I think has snuck in as an unintended trick question. So the upper limit of fixed flexion deformity in which a uni knee should be considered is 10 degrees of fixed flexion. And the reason for that is the same with an osteotomy. Once you get beyond 10 degrees of fixed flexion, it starts to really significantly affect your gait. And with both uni knee and HTO, you can't really correct fixed flexion very well. You might think you're correcting a bit, taking a bit of anterior osteophyte off or something like that, but broadly that fixed flexion is going to stay post-operatively. You can't correct it like you can with total knee. And so you don't want to leave a patient with more than 10 degrees of fixed flexion. Below 10 degrees of fixed flexion, they'll probably cope with it. So that's the answer, 10 degrees, and 2/3 of people got that right. So the uni knee with the lowest 10-year revision rate, there was a slide with it, with a box around it, and it is the Zuck, which is currently sold by Lima, previously sold by Zimmer Biomet. It's a fixed bearing knee, a fixed bearing uni knee. It's not as widely used as the Oxford, because the Oxford, I think, probably got better marketing and also do a lot more research into partial knee, and tend to try and propagate the use of uni knees, and obviously they've got a very good course and that kind of thing. Having said that, the Oxford data is sort of clouded over the years by various different iterations of the Oxford and different iterations in instrumentation. And if you look at both the results with the uncemented Oxford, which is their sort of favourite at the moment, all uncemented components, and if you look at the Oxford when the modern instrumentation is used, both have a revision rate around 5 or 6%, which is comparable with the Zuck. So it is reasonable to be using an Oxford, providing using a modern technique, which I would argue that I do, hopefully. Leading indication for uni knee replacement NGR 2019. Well, this is my trick question, because I realized as I read this question out, I showed you a slide demonstrating it was pain, but that was the NGR 2018. And the reason in the most up-to-date NGR is progressive arthritis by 0.1% over aseptic loosening, and significantly ahead of pain, actually, which was down at about 2% of the sort of 10 or 12% of revisions across all unis. So the reason it wasn't progressive arthritis in 2018 is because that came under other causes for revision and it wasn't separated out. But they do now. They report the uni revision separately. In osteotomy surgery, Fujisawa's point is not 62% of the way across. 62% of the way across is the number we all say is Fujisawa's point, but is not Fujisawa's point. He described a point from a third of the way from the center to the lateral edge, which, when you think about it, is 67% of the way across. Frank Noyes described 62. Number 10, all of the above, obviously. This was to make sure you've been listening. 91% were.
That's great. And Simon, you've got, we're doing okay for time. We've got 10 minutes. Do you want to go through your questions?
Yes.
Is that okay?
Yeah, sure. Okay, so I'll try and be quick. What most accurately represents the risk of recurrent patellar instability after a first-time dislocation? So answer A is less than 10%, B is 10 to 30%, C is 20 to 50%, D is 30 to 60%, and E is over 50%. Next, the medial patellofemoral ligament provides up to 72% of the straight to lateral patellar translation and extension. As mentioned in the talk, its tensile strength is approximately 200 newtons. Which retinacular structure has the second greatest load to failure? Is it the transverse fibers of the medial retinaculum, B, medial patellar meniscal ligament, C, the medial patellar tibial ligament, or D, the lateral retinaculum? 3, which constellation of anatomical features convey the highest risk for patellar instability? A, generalized hyperlaxity, valgus limb alignment, trochlear morphology. B, valgus limb alignment, trochlear morphology, and tibial tuberosity offset. C, patellar height, tibial tuberosity offset, trochlear morphology. D, trochlear morphology, medial retinacular continuity and patellar height, and E, trochlear morphology, medial retinacular continuity and valgus limb alignment. 4, the MPFL is on average 55 millimeters long and 15 to 17 millimeters wide. Which graft choice most accurately reconstructs its biomechanical properties? Is it a gracilis, A, B, semitendinosus, C, a strip of quadriceps turn down, D, tibialis anterior allograft, or E, a 2 millimeter fiber tape. Other tapes are available. 5, when performing plain radiographs for patients with patellofemoral instability, which views are most important? A, AP lateral and a Schuss, B, AP lateral and a Rosenberg, C, AP lateral and a skyline at 60, D, AP lateral and a skyline at 30 and 60 degrees, and E, AP lateral skyline and 30 degrees. 6, which investigations are essential before planning surgery for recurrent patellofemoral instability? A, plain radiograph and a CT scan. B, plain radiograph, CT and an MRI. C, plain radiograph, long leg alignment and MRI. D, plain radiograph, CT, MRI, long leg alignment views. Or D, plain radiographs and MRI. 7, which ratio is most appropriate for diagnosing patella alta? Is it A, the Caton de Champ, B, the B-Dirt, C, the Blackburn Peel, D, the Insel Salvati, or E, the Linklau? 8, you're performing an MPFL reconstruction and checking for graft isometry. The graft is loose in flexion. Your femoral insertion is A, proximal, B, distal, C, anterior, D, posterior, or E, proximal and anterior. 9, when performing a tibial tubular osteotomy, what is the best biomechanical configuration for the fixation screws? A, is it angled cranial from distal to proximal? B, angled caudal, C, orthogonal, D, divergent, or E, convergent? And I realised that quite a few of those questions weren't necessarily covered in my talk, but maybe you have a punt.
Great, thank you. Thanks for those questions and thanks for putting those together, guys. I know it takes quite a lot of time to do it, but I think they are valuable, particularly when they're able to see what, you know, how their peers have all answered as well. So we've got 63% of people voted, 66. We'll just let it get up to around 70 and then it's stabilized out now. Okay, so end poll and share the results. There you go, Simon, if you could flick through those now.
Okay, well, so I think in terms of the first question, the risk of a recurrent patellar instability episode after a first-time dislocation, it looks like the majority of people are on point there with answer C, 20 to 50%. I'm not really sure there's much more to say about that. It's just a raw statistic, but you know, the important thing to remember is that it's up to 50% of patients can have a further instability episode, which is why doing an MRI scan is very beneficial, because half of them will go on to have further problems and you'll be able to pick up risky anatomy. So the second question, in terms of what provides the second greatest restraint to retinacular structure, is the second greatest load to failure, so that's the medial patellar tibial ligament. That shouldn't really be a huge surprise, and everyone's got the answer there, just in terms of, if you think about its actual attachments from bone to bone rather than the patellar meniscal ligament, which is obviously attaching to the soft structure that is the meniscus, and then the pure retinacular structures, which are more sheet-like rather than a true condensation. So I think most people got the answer, which is good. And then this one was a little bit wordy. I apologize for that. Constellation of anatomical features convey the highest risks for patellar instability. The most important thing to remember there, that it's about the trochlear morphology, the medial retinaculum, and the patellar height. So the answer there is D. So the MPFL, everyone's got the answer correct there. So as I mentioned in my talk, all of the graft choices that we use are actually too strong, or not necessarily the same tensile strength, but the gracilis, being the smallest of all of these options, is the most frequently used and does most accurately represent the native ligament. When performing plain radiographs for patients with patellofemoral instability, the most important views of the AP lateral and skyline at 30 degrees. As I was sort of inferring in the talk, if you're getting a skyline at 60 degrees, the patella is going to be nearly down into the notch at that point, and therefore you're going to have a false appreciation for what the trochlea actually looks like. And then, as I was sort of batting on about in my talk, which investigations are essential, so I suppose that's the key, essential before planning surgery for current patellofemoral instability. And so the essential ones, certainly in my practice, and I'd say for the majority of people, would simply be plain radiographs and an MRI scan. So that's answer D. Obviously, everybody else is thinking longer alignment views, but you should be able to pick up from a clinical examination whether or not they're significantly valgus and whether or not that's going to be required. And then everyone's did listen to me banging on about the patella trochlear cartilage overlap and the B-dirt, so that's great. I have to say that I know a number of surgeons who use both the Caton de Champ and the B-dirt, so I'm not dismissing the Caton de Champ, especially the MRI Caton de Champ, as an option, but I would hope, if you get the opportunity and you are treating people with this sort of biology, that you should try to start in those. You'll find it quite a fruitful way. 8, performing bowel reconstruction, checking for graft. Graft is loose in flexion, so we've said high and tight, low and loose, and so that's everyone's thoughts. So on, and then when performing a tubercle osteotomy, what's the best biomechanical configuration for the fixation screws? And most everyone remembered what I said, which is if you aim them from proximal to distal or angled caudal, that has been demonstrated only at the moment in finite element analysis, but that's only because I haven't actually published my master's thesis yet because I've been lazy. Okay, so that's everything there, Mike.
That's great. Just number 8, I think we missed your answer.
Did I? Oh yeah, so that was the high and tight and the low and loose. So that's the answer is B. It's 2 distal.
Wonderful, that's great. And well, thanks to all the panelists. Thanks to Chris and Graham also for joining us. We really appreciate you putting the time into to do this. As I say, we're not entirely sure next week what, but hopefully we'll get something on. And we'll try and keep it on going over the summer as well, because we are getting good feedback. And so it will be advertised, I guess, on the BOTA website, on my personal Twitter, which is at Mike_Hayton, I think. But you'll all see it around. So thanks everyone. Enjoy the rest of the evening, what's left of it, and have a good week ahead. All right. Thanks a lot.
Thanks very much.
Bye.